Well, hello, everyone, and welcome to Network Commons. I apologize for our delay. We had a little technical problems there at the end, but we're glad we've got all of our speakers online now. So this is the Build Healthy Places Network's live discussion series on cross-sector strategies to improve neighborhood health and well-being. My name is Doug Jutte, and I'm Executive Director of the Build Healthy Places Network. Today I have the honor of serving as the moderator for our discussion. And because I'm also a pediatrician and public health professor at UC Berkeley, I'm particularly excited about today's conversation. Our topic today is on how hospitals and healthcare systems are investing in neighborhoods and how the healthcare sector can leverage the investments made by community development to improve the health and well-being of children, families, and residents of local communities. I hope that many of you today have, joining today's call, have had the opportunity to participate in one of our past Network Commons events. But if you're from the health field and have not had a chance to briefly explain the term community development so that we're sure we're all on the same page for our discussion. While many in health often think of community development as an activity, the bringing together of multiple stakeholders to improve a neighborhood, importantly, community development is also a multi-billion-dollar sector of the American economy. This largely nonprofit industry invests in low and moderate income communities through the financing and building of things like affordable housing, grocery stores, health clinics and community centers, charter schools, small businesses. They do job training programs and services to support vulnerable children, youth, and families. All factors that we know are upstream determinants of health. So I used to believe that a county or a city simply identified a need for in a neighborhood, or a grocery store in a food desert, and then simply hired a construction company to build it, all taken care of. But it turns out that it's much more complicated. It turns out that the community development sector does this work and has for decades. For example, HUD, the Department of Housing and Urban Development, that many of us are familiar with, has only built about 5% of the several million units of affordable housing that have been built over the last 40 years. This is a surprise to a lot of people, as it was to me. Instead, this work is done by a national network of organizations. Some are called Community Development Financial Institutions, or CDFIs. They're basically nonprofit banks. And also local community development corporations, or CDCs. These are neighborhood nonprofit grassroots organizations. And also private, usually nonprofit, affordable housing developers. Together, these organizations develop and finance these efforts to improve low-income neighborhoods using billions of dollars in federal tax credits, state and local resources, and hundreds of billions of dollars in private investment. What we're going to talk about today is how can the healthcare sector play a role in this arena, in guiding this work, in identifying health impacts, in direct investment in these community development efforts. And more importantly, the question of why. Why should they do that? Why should the medical sector and public health stretch beyond their usual realm to partner with community development and investors? Fortunately, we're lucky to have three national leaders joining us who represent various facets of public health and healthcare who are going to bring us their perspectives. You can read details on their full backgrounds by clicking on the links you'll see in the chat box, but I also want to provide brief introductions. So first, I'd like to welcome Quentin Moore. Quentin's joining us today from Livonia, Michigan, where he serves as Director of Population Health and Disparities Prevention at Trinity Health, a national nonprofit Catholic healthcare system that operates incredibly 90 hospitals and over 120 continuing care facilities in 21 states. Quentin's played a critical role in improving Trinity Health's community benefit programs and in developing appropriate metrics to assess population health outcomes in its various communities. Prior to his work at Trinity Health, Quentin worked extensively as a community health specialist at the University of Michigan's health system and the Michigan Public Health Institute. Next, I'd like to welcome Tyler Norris. Tyler's Vice President of Total Health Partnership at Kaiser Permanente. Based in Oakland, California, he helps lead the implementation of Kaiser's anchor institution work, leveraging such resources as payroll, procurement, investment portfolio, facilities, and grant making to address the physical, mental, social, and spiritual well-being of Kaiser's members, workforce, and the communities they live in. Kaiser also founded over a dozen businesses and social ventures and has 3 decades of service in public, private, and nonprofit sectors. And finally, I'd like to introduce Mary Pittman. Mary's president and CEO of the Public Health Institute, or PHI, based in Oakland, California as well. Mary's been critical in leveraging PHI's many programs for state and national policy advocacy efforts, particularly around healthcare reform, health workforce shortages, and the impacts of climate change on public health. Mary has varied experiences working across public health and healthcare. Was actually an early advocate of healthy communities, movement with Tyler Norris. Prior to her work at PHI, Mary served as president of Health Research and Educational Trust, an affiliate of the American Hospital Association. Was president of the California Association of Public Hospitals, and as well as a director of the San Francisco Department of Public Health. So thank you all for coming. We're really pleased to have you join us here today. We're going to kick off things with just a couple questions for our speakers, but I want to move quickly to our audience. I want to thank all of you who submitted questions earlier while registering for the event. We have several dozen questions actually already. And for those of you who want to share questions or comments now, you can use the chat box that shows up on the right side of your screen. We'll also be using Twitter, so you can send us, and the rest of the world if that works, messages by way of our hashtag #NetworkCommons, all one word. And we'll try to get to as many questions as we can. So I want to open today's discussion by first asking each of our speakers to discuss how hospitals and healthcare systems are thinking beyond medical care to address health and well-being, and importantly, why are they doing it? Mary, if I can, I'd like to start with you. Based on your extensive experience across the public health and healthcare sectors, can you give our viewers a sense for the big picture? Historically, hospitals have been both medical providers and major employers in their communities, something that's termed anchor institutions. But now there's an increasing focus on prevention and population health. Why is that happening now?
Thanks, Doug. I think we have to go back to the ACA, and I'm not going to take you through a whole lesson on the ACA, but it's important to think about the goals and the approaches that were baked into that piece of legislation, such as increasing coverage and benefits, including preventive care, which is really important, preventive care without cost sharing. And also an emphasis on the triple aim, which would improve quality, make a focus on improving the health of populations, as well as getting a handle on reducing the per capita cost of health care. And I think all of those elements are really critical to consider when we think about why hospitals now are paying more attention to population health and investments in community. I think the greatest impact of the ACA was moving from volume to value. That is, having responsibility with your resources to cover, the full continuum of care, and not having a fee-for-service pay for each effort that you take on, but in fact, looking at a full coverage under a fixed rate. There are also certain hospital requirements, such as community benefit provisions, that relate to nonprofit hospitals, and 60% of hospitals in this country are nonprofit. And in that community benefit requirement, there's expanded transparency on how community benefit dollars are going to be spent, and how the community is actually engaged in the process of not only assessing needs, but also in putting together an implementation plan. We'll touch on some of these elements as we go through some of our questions later. But again, going back to the cornerstone of the ACA was expanded coverage, and particularly with Medicaid. And what we've seen is that 20 million out of the 50 million uninsured have in fact been covered by the ACA. So you would say, why are we more concerned with prevention? People have coverage, but we know that coverage expansion does not equate to health. And in fact, there is a big gap between having an insurance card, being able to access health care, and being healthy. And that depends on where you live, your economic position, and a whole variety of other what we call social determinants of health. In some places, even if you do have insurance, it's difficult to access a provider, particularly if you have Medicaid. And you may be challenged to pay your copay or your deductible. And 90% of Americans are still getting access to their insurance through their employer. Are getting access through state and federal. 90% of Americans who are getting their access through the federal exchanges are getting some form of subsidy. And that's really important to keep in mind, because addressing the cost of healthcare and addressing the rising cost of premiums really has to be critical when we think about what the role of hospitals are and why they would begin to look at a different paradigm for reducing costs, because it hasn't worked so long. Let me just take 1 minute to note that even people who get their insurance through employers, and 40% of workers with employer-sponsored health insurance now have a deductible of $1,000 or more, and 20% have a deductible of $2,000 or more. And the proportion of Americans with higher deductibles keeps going up year after year. The Health Research and Educational Trust, where I used to work, and the Kaiser Family Foundation have been doing an employer insurance study for many years. And what we've seen is that health insurance premiums for a family of 4 in 2005 was about $10,800, of which the employee covered about $2,700. Now, in 2015, the average cost for a family of 4 is $17,500, of which the employee contributed almost $5,000. That's a huge increase, and it's really causing a challenge for people who are insured but have these large out-of-pocket payments that they still have to make. So the economic pressure to reduce costs is coming from employers, it's coming from government, and hospitals are having to learn how to manage not only their traditional employer-sponsored patients, but they're also having to learn how to deal with Medicaid, newly enrolled, people who haven't used the system before, many of whom have great pent-up demand. So I think that's where the conversation in the boardroom, the conversation in the physician conference rooms, and certainly CEOs are having a different dialogue about how to address both the high costs and this shift towards value, where they have to be taking care of a population in a more cost-effective and, quite honestly, out of hospital in the community. Let me stop there. We'll touch on some of the other points later.
Great, thank you. One term that, if our viewers are unfamiliar, is this idea of volume to value. That's become a real touchstone recently in the sort of medical world. So I want to turn to you, Tyler. You might say you literally wrote the book on hospitals as anchor institutions. We're going to put up a link to the report that you did, in fact, write about anchor institutions. So I want you to talk a little bit about how does Kaiser define its role as an anchor institution, and how does that guide your decisions around investments in the community?
Doug, thank you and good morning. Great to be part of this conversation. Appreciate the invitation. I think to begin to understand our why is to know our model as an integrated delivery system. And what that means is that to our 10.5 million members, we offer a health plan or coverage along the lines of what Mary discussed, and we deliver care, so care and coverage together. And what that means is that we are essentially, therefore, at risk for our members, and we are at risk, an insurance model, for the health of our communities. So rather, again, than being paid for volume of care services, we actually do better when people are healthier and communities healthier. So our incentives are aligned from the beginning and are very much where the Affordable Care Act is pointing organizations to go at risk for the health of the communities. So think about our organization then. We have finally, over the last decade or so, become one of the highest quality care providers every place that we operate. So we're providing high quality care. And we do that at the best possible price. And as we participate in the Affordable Care Act and participate in the exchanges and particularly participate in Medicaid expansion, we are taking on more lower income members who are honestly more at risk or more vulnerable from chronic disease and actually cost more in the system at the very same time that our reimbursement is being reduced. So think about this equation, that you're trying to maintain highest quality care for more people who are less healthy than the people that you already have, and you get paid less for that. That's essentially the equation. So if we're at risk for the health of the communities, but we only control, to Mary's point, 10% of what creates health through the medical delivery system, and the rest of it, in addition to genetics and biology, is housing and transportation and income and education and access to food and all those things that we know are in the community economic development space of this conversation, then we essentially have to figure out how to do that better. And we can't do that alone. It's not our area of expertise. So it creates this natural opportunity between the sectors, Doug, as you've described it. So when we start to hone in then, again, just thinking strategically as a health system so you can kind of understand it, about 1% of our members drive about 23% of cost, 5% drive 50% of cost. And we know where those neighborhoods are. And the whole spirit of this conversation is place matters. We've got to be in the zip code improvement business. So if we start to hone in on the social, economic, and behavioral needs of our members, not just the clinical needs, but those things that are essentially impacting chronic disease, somebody with diabetes or hypertension, if there are not safe places to be active, if there are not easy ways to access healthy food, if there are not affordable, safe places for housing with support services, if there's not access to home care and community health workers, and, no matter what kind of quality care we provide, we're essentially discharging somebody back to a community where there's no way that they can do what a doctor says to actually be healthy. So what's happening in that equation is that communities are essentially driving the demand on the healthcare delivery system through the need for more and more care for chronic disease services that are driving 80% of a $3 trillion spend. Now, we tried to go after that through better community health investments, and we learned a lot about dose, more reach for people, more intensity, stronger interventions, more duration, staying in communities longer. All our grant commitments now are in the 5, 7, 10-year time frame. But that wasn't enough, so the anchor institution strategy says, well, we may be doing a couple $2 billion a year of community benefit, charity care and coverage and grant making, but what about the other 96+% of our organization? The 20 million in living wage jobs, and how do we develop workforce pipelines from the community so that we increasingly hire locally and create living wage jobs in the communities that we serve? How do we shift our procurement to buy more locally and not only create more jobs locally, but circulate wealth locally so that that multiplier occurs a couple of times before that contracting dollar essentially goes off to Wall Street, that it circulates on Main Street more. And through our environmental stewardship and green purchasing, and through our buying healthy, affordable, fresh foods and helping scale the local food economy through grant making, through contracts, through a couple of multi-year purchasing contracts, and even through impact investing, we're essentially looking at how, with our facilities, with our procurement, with our impact investing, with our hiring, with our IT, how we use the majority of the operational levers of our organization to drive community health. That's the anchor role, not just some great community social responsibility strategy, but how do we create social value in literally everything we do. So, and that needs to happen with friendly competitors in our region, other health systems, as well as universities and others, to have a strong enough investment that could actually improve community health. And maybe, back to Mary's point, if we go all in with everything we have and all of our partners, maybe we can improve the health of the population and reduce preventable demand on the delivery system that is driving the costs, which would allow healthcare costs to come down and make healthcare more affordable. That's the equation here. Healthier people, healthier places with less demand on the delivery system that would allow us to invest scarce healthcare dollars back in education and transportation and housing and food and all those things that actually create health in the first place.
Wow, no, that's really great. I want to repeat something you said. I want to note here, Tyler Norris from Kaiser Permanente said, we've got to be in the zip code improvement business. That's fantastic. And I think that idea of making the dollar circulate locally before it goes off to wherever it goes is another sort of just key point I wanted to highlight here. So Quentin, we're sort of marching down. So Kaiser has an incentive, given its structure, to invest in the neighborhood. But you work for a large mission-driven healthcare system. Now, you're known for your commitment to the elderly, the poor, the underserved, but a lot of that's mission-driven. So how does Trinity address population health beyond providing medical care?
Sure. Thanks, Doug. So Trinity Health is a 90-plus hospital integrated system in 22 states, and we value community benefit as a core of who we are and a key component of our mission. Community benefits are programs, activities that provide treatment or promote health and healing to identify community needs. approximately $1 billion were provided by the Trinity Health System in our most recent fiscal year for programs, subsidized services, and training for new health professionals. So definitely something that we value as a key component of our organization and as a key core of our organization's mission. As we implement those community benefit programs, we conduct community health needs assessments, which, as Mary mentioned earlier, are requirements of all nonprofit hospitals. Luckily, Trinity has a long history, over 15 years or so, in conducting these assessments. As a result of the ACA, which has required all hospitals to conduct CH&As, there has been an increased focus on within our organization on ensuring that we're engaging additional partners outside of those that we traditionally see as being collaborative organizations to work with as a health system. We've begun to engage health departments, community groups, and other leaders to really get their collective voice and understand what their needs are and not try to make an assumption of what they should target or what we should target to address within those communities. As a result of these needs assessments, we've increased our focus as well on evaluation. You know, how can we ensure that the dollars that we are stewarding, the $1 billion plus in dollars, are really providing the most value back to that community? And if not, how can we right-size those strategies? So over the last few years, as a result, again, of the ACA, we've begun to work more aggressively with our board and have identified a community health and well-being strategy that aligns very well with the required CH&As. That new strategy has three major pillars: clinical, community engagement, and community transformation. As a health system, we continue to prioritize those clinical community concerns, but also are beginning to move more upstream to address many of those challenges that may be prevalent within a community that may be outside of the scope of healthcare systems. Beginning to look more from the standpoint of policy, system, and environmental change, as well as addressing those social determinants that are prevalent within each communities. As we begin to align our efforts with our mission more readily, it allows us to build upon the strong history over the years that we've attained through much of our efforts, and probably most importantly, allows us to really amplify the efforts in our community and work in alignment and in collaboration with others that may be conducting needs assessments who have identified similar concerns within their service areas. I think from our standpoint, we see health as being more than just a set of symptoms, and definitely goes beyond treating and providing support, and really ensuring that we're providing service to the entire person. As a system, we really prioritize that and see that as our new mission and vision in this new area of population health.
Thank you, Quentin. Before I go to the next question, Mary, I wanted to ask you, what's your sense? Is this a growing trend in healthcare systems, or are Trinity and Kaiser and organizations like them really outliers?
No, Doug, it's a great question. It truly is a growing trend in all hospitals, whether they're large systems or even smaller rural hospitals. And there are some great examples of the work that are being done, across the board. And I think, the the CEO and the boards of directors are looking at community benefit in a different way. It used to be something that was not high on the priority or the agenda at board meetings, but now it's front and center. And what you see is that organizations like Kaiser have decades of experience, but there are some who are just entering this since the ACA passed, and they had to develop a community needs assessment and then a community health improvement plan. But you see some folks that are really making major progress in a very short time frame. And saying something like we're in the zip code improvement business, you have to assume that a community that has broken sidewalks where the elderly fall, break their hip, and there's a whole cascading effect of that, or where children can't go out and play because there's no safe place for them to play and you don't want them out in traffic, or you have empty lots that are full of garbage and just aren't hospitable, and often are sources of not only an eyesore, but often, illegal activities will take place in a discarded empty lot. So what you're seeing are communities who are demanding that there be changes happening, and those demands are incorporating the hospitals in every town to pay attention. There's a good example. Henry Ford Health System in Detroit realized that inner city of Detroit had been really devastated economically, and a lot of people have fled, and there were boarded up buildings and houses, and they realized unless they could start to help contribute to turning around the economy in that part of Detroit, and their employees couldn't live near the hospital, so they purchased 200 properties, tore them down or rehabbed them, and offered employees down payments so that they could rent or live closer to where they worked, so they weren't having to drive long distances. And then they also did one of the things that Tyler was talking about. They awarded contracts for medical suppliers to move into the neighborhood and be part of the supply chain right close to the hospital, again, having an impact on the carbon footprint, providing local jobs. And they're now incorporating mixed income housing and a cancer research center. So they've really started to turn things around in that community. And there are lots of examples of that.
Great, thank you. I wanted to note, I just got handed a note. So there's more on Mary's conversation about Henry Ford in Tyler's report and also on the guest blog on our network site that Tyler wrote. So you can find that there. Let's go back to, actually I wanted to point out one thing that I jotted down and forgot to mention is just thinking of the scale. You guys heard Quentin mention $1 billion in community benefits. We're talking about very large sums of money, and I want to highlight too that historically community benefit has really been sort of a retrospective. What's the money on that we weren't paid back for and can claim for community benefit? And what you're seeing here with Kaiser and Quentin's work, or Kaiser's work with Tyler and Quentin's work at Trinity, is that they're thinking proactively. How can we invest proactively as a benefit? So let me come back to you, Tyler. So I didn't mention the scale of this work earlier, but the community development sector is about a $200 billion industry. So how does Kaiser, how do you use CDFIs, these nonprofit banks, and other players in community development as you work towards investing in communities?
Well,
you can keep it brief, Tyler.
We want to build on Mary's and Quentin's excellent comments sort of about being very deliberate about this. And as Quentin's saying, we're not just putting out charity care and coverage and grants. We're really, I think our sector is becoming much, much more rigorous about how we invest and create outcomes. So let me kind of answer your question by imagining the process inside a care organization. So let's say we're working with somebody who's a pre-diabetic at risk of becoming a diabetic, and they're relatively low income. We give them the best care we can possibly provide, and we essentially send them back to their neighborhood, right, where there may be a food desert and not access to healthy, fresh foods. There may not be safe neighborhoods, housing is substandard or doesn't have supportive services. It is almost impossible to give a behavioral prescription, eat healthier, move more, cut the tobacco, moderate the alcohol, and to send somebody back to a rough community and expect that they're somehow going to change behavior when in fact the environment conspires against them actually making the healthier behavior change. So one of the things that we're increasingly doing is in a partnership with Health Leads, is to refer our members and patients to community services, such as access to healthy food, to help them find safe, affordable housing, to get non-emergency transportation, whatever they actually need that would help them follow through in what the doctor has spoken about, again, to help that pre-diabetic to not become a diabetic. So what we've been doing with Health Leads is then referring to organizations, and we're beginning to see a pattern of what organizations we're referring to, what the capacities are of those organizations, and where there are gaps. So now we're in a partnership with the Nonprofit Finance Fund, a great CDFI, and we're partnering to assess the capacity of those community-based organizations to essentially receive those referrals and to be a strong partner over time, prospectively for data exchange and even reimbursement for what they're doing to care for members. But as we uncover kind of what the gaps are in the community around those factors that are so critical to impacting health, again, that are outside the medical care delivery system, then we start to think with our anchor resources, how could we do impact investing into, whether it's across asset classes to loan guarantees for affordable housing, or maybe direct investment, as some of the Catholic health systems like Trinity Health and Dignity Health have actually done. For example, with access to healthy food, we can make grants, we can buy from local growers and distributors in multi-year contracts. Schools and other providers can do the same thing, so you essentially create a series of multi-year contracts that are bankable by a small business to go to the bank or get a loan against that collateral to grow or expand their business. Or we could come back around with impact investing and invest directly into that. So that's kind of how we're targeting on the social non-medical needs, making referral, using capacity assessments with CDFIs, and then partnering with CDFIs as intermediaries to do what they do best in community development, while we provide great care and try and create much more of a partnership relationship. What I think we're talking about here is building out not just an access to health care infrastructure, but an access to health infrastructure that essentially requires everything that resilient, equitable community development and that entire sector brings. That's why this kind of a cross-sector partnership is so vital.
No, I appreciate that, Tyler. Go ahead, Mary.
I was just going to say that I think that Tyler's lifting up something that is probably one of the greatest changes in healthcare, and that is really establishing these partnerships across different sectors. That's the biggest change that I've seen at a very deep and broad level in the last, say, 5 to 10 years. And so that gets replicated over and over again, and we see these new community organizational forms emerging, some of them from legislation, like the Oregon, coordinated care organizations, or in California, we have the Accountable Communities for Health, and there are a whole variety of those. But we're also seeing these non-regulated, non-legislated new forms and partnerships that are very exciting. And I'm sure Quentin can talk about some of Trinity's experiences, which have been quite extensive as well.
Yeah, absolutely, and I think Tyler, your point, which is, again, as a physician, it's shocking because we spend so much time thinking about access to healthcare, and you're really talking about access to health and what's the role of Kaiser in that. So yeah, Quentin, let's get to you. So Trinity, I'd like to hear a little bit about how Trinity Health has moved beyond. We've talked some about community benefit. How have you moved beyond community benefit requirements to more actually engage in neighborhoods and community development through direct investment?
Sure. Again, I think the Affordable Care Act really positioned the bill from much of the historical work that was done within the Trinity Health system. As I mentioned previously, our community health and well-being framework, really looks at clinical community engagement and community transformation as 3 key core areas that we see as really supporting our movement to this next stage of healthy environments. So recently we launched a new initiative, Transforming Communities, which is an $80 million grant, community match, and loan investment program that really brings together many of those key leaders that Mary mentioned in the community, hospitals, public health agencies, and other key community organizations and leaders. To me, what's most exciting is the inclusion of the economic development sector. So these multi-sector partnerships are working to address in our communities healthy eating, tobacco-free living, physical activity, obesity, and other community concerns that may have been identified by the respective communities. We fund 6 communities in our first cycle, and our goal really is to identify how we can ensure sustainability of efforts in the absence of dollars. I think many of us that have coordinated and conducted or been funded through grant programs know that oftentimes once the funding ends, the big question comes up, now what? So our goal is really to identify and to plan an approach so that now what question is solved. And I think the engagement of that development sector can really help bridge that gap between the funding and the overall sustainability of those efforts in the communities. With the new TCI initiative, in order to approach and provide us with the opportunity to address that now what question, we've engaged a number of technical assistance partners. The Georgia Health Policy Center, Change Lab Solutions, the Public Goods Project, Community Catalyst Campaign for Tobacco-Free Kids, and also two key CDFI partners, IFF and TRF, the Reinvestment Fund. So historically, Trinity has a long history of investing in CDFIs through our socially responsible investing program. You know, I think what's really exciting about this new work is definitely the alignment. As Tyler mentioned, we often did that because it was right. It was the right thing to do. But we often didn't align it with the efforts that were being conducted in our community and with the needs identified by those local individuals. You know, rightfully so, we should include in all decisions. So by engaging these new CDFI partners, it will allow us to address those social determinants, including a specific focus on housing, food access, and early communities in alignment with those core strategies of tobacco-free living and healthy eating. Likewise, by engaging with the CDFI partners, it will allow us to support the vision of integrating program strategy and policies across the community to really address that now what question and create an environment of sustainability. By supporting the improvements in the communities, again, it will allow us to scale and ensure success beyond funding. So our long-term goal really is to create and identify a vision and goal of ensuring that healthy communities is the default outcome, regardless of the prior circumstances in that environment.
Great, I appreciate that. And I want to point out how sort of cutting edge it is that Quentin's talking about working directly with a couple of these CDFI. So the FF and TRF are two of these national community development financial institutions. Before I move on, we're going to open up the questions. I wanted to give, Mary, I went slightly out of order earlier. Did you have anything you wanted to add? I was thinking specifically around the issues of measurement.
Sure. I think, you know, one of the things that we've learned is data is key, and hospitals and health systems are having to learn how to embrace different forms of data than they had before, different sorts of metrics. And we've had data in public health that have established national goals like the Healthy People, you know, 2020, which, you know, we've had since 2000 at decade goals. But some new emerging, I think, data sets have really been incorporated more into the thinking of hospitals when they're looking at how do we improve community health, including the county health rankings that the Robert Wood Johnson Foundation funded. And at first people didn't pay a lot of attention, but now that's been a major driver in many communities when they're taking a look not only at their hospital and community needs assessments, but also more broadly other community organizations are looking at how do we compare not only in our own progress, but also with other organizations and other communities that are similar to us. CMS, the Center for Medicare and Medicaid, has been trying to stimulate innovation and providing funding both for state and local organizations to try to shift the needle to begin to look at new ways both to organize and deliver care so that it's more innovative, more engaging in the community. And they've really been driving for different metrics in exchange for significant funds to begin to develop some of these new models of care. We don't have all of the evidence in yet, but there are some examples that are showing real progress. So I think that shift to new forms of data. Here in Alameda County, we have a consortium of 6 hospitals that have come together to deal with the small percentage of high utilizers that go from one emergency room to another with uncoordinated care. By sharing data, which is really a relatively new phenomenon, we're able to see that better coordinated care results both as an improvement for the individual whose care is being coordinated and getting the appropriate kind of care, not necessarily care in an emergency department, but it's also going to be reducing cost in those health systems that just had frequent flyers coming in and using services without really seeing a positive impact in their health outcomes. So I think that data is really key, and I would also have to add leadership. I mean, again, I'm emphasizing that leadership both at the community level and also within our health systems is really shifting how they view these, what have been seen as intractable social problems, and not them, but to in fact see that those social problems have a lifelong impact on individuals, which makes them unhealthy. Let me stop there, and I know we have a lot of questions from our audience that we probably want to address.
Yeah, I want to point out just a couple for our audience, a couple of resources, and if my team can put up links on the chat box. So one is our Jargon Buster. We've been tossing around a lot of terms, and our Jargon Buster explains things like CDFIs and CDCs. I also want to point out, in sort of response to Mary's comments, we have a portal called Measure Up. So we can put a link to Measure Up. It really pulls together examples of how measurement and metrics are being used by both the community development and health sectors to look at neighborhood. And last, I want to mention community close-ups. We've done a series of case studies, including 2 focused specifically on hospital investments in community. One of them is the Children's Hospital of Philadelphia, and the other is taking place in Stamford, Connecticut. So if we can get links up to those, that would be great. I want to actually come back to you, Quentin. One of our viewers via our chat box, I noticed, specifically asked if you could provide a little more specificity. Can you give us an example of one of the investments? She mentioned one in Michigan. Can you give our audience a little bit more of a sense of how Trinity is going beyond the normal hospital system and actually investing?
Sure. So I guess probably one of the largest investments that occurred more recently was this was actually in Ohio. Trinity funded one of the local CDFIs in the Columbus area to support the build out of a new grocery store, knowing that food access has a direct relationship to health outcomes. This was really exciting opportunity that occurred, and really I think just shows the potential value in aligning with the development sector. Within Michigan, we are currently exploring a number of opportunities. I had an example in mind, but I'm not sure if I can share it yet. I can talk in generalities. But really, it's looking at the concept of creating an entire multi-sector facility that provides not only clinical care but also support for other social needs within the community. So we continue to look at new opportunities, and we just launched this initiative late last year, and I think it's definitely a wonderful time and a wonderful approach, because it really is beginning to allow us to see the parallels in what communities are doing. Oftentimes there are 5 different needs assessments that have been conducted across communities, and unfortunately, X organization may not be talking to Y organization around the corner, and I think this new approach is really bringing all those parties together. So we've really prioritized, really developing and working across sectors in partnership with organizations that may not normally be an entity that we often work with. The way we see the model moving forward is really providing additional expertise and support within our communities, providing information on how to access capital, how to write a business plan, how to look at development opportunities, and really leaning on our 2 national CDI organizations to provide that support to our community health leaders, our community benefit leaders, and in turn having them engage with other entities within their community that may have that interest in receiving those dollars. But a lot of our work really just revolves around trying to engage individuals from multi-sectors so that there's the opportunity to build not just a housing new housing development, but how to integrate housing with with food access and other concerns, so that it addresses more than one issue within the identified community.
Yeah, Quentin, off the top of your head, oops, I think I'm echoing. Do you know the name of the grocery store in Columbus or the hospital? What Trinity Health hospitals do you guys have there? Do you know off the top of your head?
So our hospital in the Columbus area is the Mount Carmel Health System.
Mm-hmm.
And
Great. Do you know the name of the grocery store by chance?
Unfortunately, don't have the name.
All right, we'll try to find that out and let everyone know.
Yeah, I'll be happy to give information.
So let me see. I got some questions here. Oh, here we go. So I'm being handed questions. So why don't I actually? This question has come up a number of times. And it's always a question for me as well. Is where are the cost savings that can drive this externally for healthcare systems? And I think the question may go. It really could be any of you. But Tyler, where do you see the direct cost savings, or have you seen specific examples of this? Or Quentin, do you see specific examples of cost savings that will turn this from being a mission-driven effort to being one that's driven by actual savings within your organization? Tyler?
Sure, happy to start with that. It's a great question, and there's a few ways that I'd like to sort of get at answering it. The first is that it is our job as mission-driven nonprofit organizations to improve health. So that's who we are, that's what we do, and that equation is at the heart of why we do what we do. And we can talk about cost, but let's just remember what our job is in the first place. It is to do that to begin with. Whether in a secular integrated delivery system like ours or a faith-based system like Quentin's or others. Secondly, that when you have people that have mobility and access to transportation to get to work and care, that have access to healthy, fresh foods, that live in stable housing with support services, they can go to school, they go to work, they access care, they're part of a healthier neighborhood, and that makes them more productive overall. So they're contributing back to society. That is an important impact to our local economies and to our nation. There are early signs of places that there may be cost reduction. For example, Hennepin Health, that is a safety net provider in the Minneapolis-St. Paul region, has a global payment waiver from CMMI right now, and they're receiving a fixed amount of money to care for 10,000, soon 20,000 Medicaid members. They have taken some of that global payment and put people in stabilized housing with support services around it, and noticed emergency department visits reduce. So you're making an investment on the one side in that. Many initiatives around asthma, for example, of cleaning house from dust mites and rats and mold and that may cause asthma, or even something like Propeller Health's investment in an asthmopolis that actually has a GPS on it, so you can see where asthma is being created in a hot-spotting way and address it. Those are ways that we've started to see a cost reduction. But to really get at reducing chronic disease, again, the 80% of the $3 trillion spend, I can hardly get it out, so much, we're going to have to view this as a longer-term investment, 5, 10, 15, 20 years, to actually see a reduction in chronic disease rates that are really going to save money and allow us to, as I was describing before, reduce preventable demand and bring healthcare costs down. So yes, it's our job. There are some early signs, but to really be able to capture this, I think we need to think about it in the same kind of time frame as you think about raising a family.
Yeah, yeah. Quentin, is there, you obviously are dealing with the same issues that Tyler's talking about, that we believe there are cost savings. They will happen over time. Has Trinity been able to identify any specific savings yet, or is this more generally a belief that long-term this is going to be of value to your system?
I think, again, echoing, much of what Tyler had stated, we look at it as a long-term investment. We understand that, investing in communities, especially in working around the prevention space, it takes time. And our system is committed to, serving and providing support as a core aspect of who we are as an organization. I know there are some studies that have come out recently, with modeling around the potential impact of smoking policy interventions and obesity interventions. And we're definitely monitoring that and including many of those aspects into our Transforming Communities initiative. But from a system standpoint, our board of directors is very supportive of this new strategy and recognizes that community health doesn't happen overnight, that it does require resources, it requires support, and it requires time. And so we are looking at all those components as a key as key aspects of where we see things occurring within the next 5-10 years or so. We continue to monitor and work internally to identify potential metrics to track those outcomes. I anticipate fully that with the next couple of years, this conversation will be completely different because we probably will have, the early stages of support to show, how these efforts are really changing community dynamics. But it's an exciting time, and definitely, this new strategy that we've undertaken, I think, is really supportive of really recognizing that community health doesn't happen in a bubble. That requires, the work and partnership of many groups and entities.
Yeah, no, it's a reminder this is really early in this this process, I think. So I have a new question here.
Can I mention one thing? There was a Blue Ribbon panel called Vital Signs that looked at core metrics for health and healthcare progress. And they were convened by the Institute of Medicine and supported by Blue Shield of California, the Robert Wood Johnson Foundation, and I think the Healthcare Foundation of California. They came up with 15 core metrics and related priority measures that come from an evidence base that is significant. So if people want to get more detail, they can look up vital signs. And the CDC has also come out with a new initiative, the 618 initiative, which has gone through a significant process of vetting where there's an evidence base. And you add to that some of the reports on the National Academy of Medicine, formerly the IOM Roundtable Population Health, the Community Commons, the Robert Wood Johnson Culture of Health. These have really good concrete examples of where there have been effective programs, where there are metrics that come from an evidence base. And when you ask a question, where are the cost savings, it's got to be whose costs and whose savings. And I think that's the biggest challenge we're still dealing with. There may be savings, but my savings may affect, your costs. So just that's the area that we're still, I think, trying to work on is if you have an overall reduction in healthcare costs, where does that money go?
Yeah, I appreciate that. I think that's an important issue. Whose savings and it's someone else's income. So we're almost out of time. Mary, I want to ask you very quickly. Another question that came in from the chat box is, as a community developer in a local government or a local government person, how do I engage with hospitals for these projects? If you have any word, maybe we actually all three of you very quickly answer that. So anything from your experience from the higher level American Hospital Association work, how do you approach a hospital? Maybe Quentin and Tyler can quickly give a response as well.
Well, I think, first of all, there needs to be, the kind of work that you're doing is absolutely essential. You're showing examples, you're putting up the jargon busters. I think going to your website and reading some of those case examples would be what I would recommend somebody who's interested as a starting point. Then I think, people will take a phone call and sit down and talk with you, and you lay out what your mutual interests are. And if those mutual interests are based on local community problems, you have a good dialogue that's ready to start. And so, just briefly, that's where I would recommend that somebody begin.
Quentin, in a word, what should somebody do to reach out to a hospital?
Well, I echo Mary's comments. Definitely reaching out to our hospitals, the ACA, and the requirements around community health assessments. We definitely are interested in partnering with within communities. So, as a requirement, all hospitals have to post community assessments online. So I encourage any party to reach out, look at the websites, and identify the contacts and process that's conducted every 3 years.
Yeah, so I think the community health needs assessments. And Tyler, any last word then before we go?
I would say that for most organizations, the community benefit team in the community would be the place to start. Those are the folks that partner with communities already. And then our procurement teams, like our National Supplier Diversity, is localizing spend, would be great on the contract side. Our investment group from CDFI around housing, and then human resources, part of workforce pipeline development for high school, community colleges, and workforce investment boards to actually create communication pathways or career ladders to a good job in the communities. I think all of those are touch.
Great. So I'll give you one last suggestion for our audience. If you go to the Democracy Collaborative site, it's called community-wealth.org or gov, I forget. You'll find they've actually done most of the big cities in the country. They've identified anchor institutions, including CDFI, CDCs, these types of organizations, with contact information, and they're also very receptive to being reached out to by healthcare systems. So with that, we are out of time. So I want to thank the three of you very, very much, Quentin, Tyler, and Mary, for joining us today. Our viewers, thank you again for all your questions ahead of time and for joining us in Twitter and online. You can continue to questions through the hashtag Network Commons, and we'll try to get some answers to you. And if you've missed any of today's discussions, we will have a link on our site soon to give you the YouTube channel. So we'll have this on YouTube, the full conversation. So thank you all, and appreciate all of our viewers, and we'll have a closeout, little summary questionnaire that'll pop up in your screen when we close out. So appreciate everyone joining us today. Thank you very much.
Thanks, Doug.
Thanks, Doug.
All right.